Hi, everyone. Thanks for tuning in and for your interest in our topic today for this applied learning case, which is titled Strategies to Promote Implementation of Standardized Assessments in Stroke Rehabilitation. I'm Lisa Juckett, Assistant Professor at The Ohio State University in the Division of Occupational Therapy, and I'm also an investigator for LeaRRn's didactic team. And I will say that I had the opportunity to share some of this information with LeaRRn's audience in fall of 2021. And so if you'd like to see more of the expanded talk related to this work, feel free to check out that archived resource on LeaRRn's database. So before I get into the details of today's applied learning case, I do want to give a nod to some key players because without their efforts, this work would not be possible. And so listed first on this slide here, Drs. Lauren Wengard, Meredith Banyos, and Amy Dara are all co-investigators on this project, which is funded through the American OT Foundation, specifically through their implementation research grant mechanism. And because this work is very much deeply rooted in the needs, preferences, and abilities of our practitioners at The Ohio State University Wexner Medical Center, I also want to give a sincere shout out to the OT department, PT department, as well as to their administrative leadership. So for today, the goals of this applied learning case is that really we'd like you to leave this applied learning case with an idea of how you yourself, within your organization, your clinic, your own learning health system, can identify a problem of interest to your own practitioners. We're going to be talking about the problem of interest that the problem of interest that is meaningful to occupational therapy practitioners in stroke rehab, but certainly this work can transcend across different disciplines and different areas of practice. We also plan to leave you with tools to help you identify factors influencing the problem of interest, as well as strategies to then address those identified factors. So first off, just a little bit of background here on stroke rehabilitation, since that is our setting. Approximately every 40 seconds, an adult in the United States has a stroke. That icon up there at the top of this diagram is supposed to indicate a large population of individuals. And we expect that the stroke survivor population will increase over the course of the next several decades as the aging population increases as well. That second icon of a brain is supposed to indicate that the leading cause of long-term disability is stroke. And one of those disabilities can manifest in upper extremity impairments. So 80% of stroke survivors have upper extremity impairments, and that could be sensory impairments, motor weakness, motor planning impairments, a combination of any of the above. And one might think that just based on that high proportion of upper extremity impairments, that OT practitioners who are often tasked with managing the post-stroke upper extremity, one might think that OT practitioners often assess upper extremity motor function through standardized outcome measures such as the Fugl-Meyer assessment, as well as the Action Research Arm Test, which are two standardized assessments that have been widely endorsed for use research and practice experts. But what we found through a survey that was conducted and administered to a nationally representative sample is that the Fugl-Meyer assessment really is not implemented all that often. Just about 5% of our sample, of our survey sample, indicated that they routinely use the Fugl-Meyer assessment of the upper extremity, and just about 2.5% administer in practice the Action Research Arm Test. And so certainly those proportions are lower than what we'd like to see. We would like to see more objective data that captures the function and motor abilities of our stroke survivor populations. And these statistics here also translate to the practice patterns that we see at Ohio State University's Wexner Medical Center, which is depicted here in the picture on this slide. And so we focus our efforts in this project that we call Implementation Strategies for Outcome Measurement, or ISTROM. We developed this project with the goal of increasing OT practitioners' adoption of the Fugl-Meyer assessment and the Action Research Arm Test, or you might hear me refer to it as the ARAT over the course of the next few minutes here together. And we wanted to administer these two assessments across the stroke continuum, meaning that we wanted to improve practitioners' use of these assessments in acute care, in inpatient rehab, as well as outpatient, so across the continuum at Ohio State's Medical Center. But to do so, we had to think through the needs of our practitioners, and based on those needs, develop what we call implementation strategies. So that would be the methods, approaches, or techniques to help support an individual's or a group's use or uptake of an evidence-based practice. In this case, that practice would be the Fugl-Meyer and the Action Research Arm test. So step one of this project was to conduct a needs assessment and really get to the heart of what was impeding or preventing practitioners from using these two assessments on more of a routine basis. And you can conduct a needs assessment in the implementation science field through multiple different mechanisms. We chose to turn straight to the literature first, just based on resources available to us at the time. And so we conducted a scoping review, and if you want to take a look at the methodology or more of the granular details of that review, you can check out the publication, open access publication that's listed below on this slide. But we evaluated the literature to try to understand more about the implementation barriers, so those roadblocks that limited the extent to which practitioners could implement the Action Research Arm test and or the ARAT. And from that, from the literature, we identified some key themes and matched those themes to language that is used in a very often cited and often applied implementation framework known as the Consolidated Framework for Implementation Research, also referred to as the CFIR. And so for us, the main barriers that we identified through our literature search was access to knowledge and information, or a lack of access to knowledge and information, poor communication, all right, I don't want to start the whole slide over again, so I'm just going to talk about these three barriers. So for us, after we went to the literature, we identified three main barriers limiting the extent to which practitioners could implement these two standardized assessments. So, and we mapped the language from the literature to the Consolidated Framework for Implementation Research, which is a widely used framework in the implementation science field. So first off, we identified that practitioners don't have, on a routine basis, access to the knowledge and information they need to implement these two standardized assessments. Along the lines of networks and communication, perhaps at practitioners' own organizations, in their clinics, in their learning health systems, they don't have communication networks set up in place, such as strong documentation systems to allow for more streamlined use of standardized assessments. And then lastly, a lack of strong implementation culture serves as a barrier to evidence use, or in this case, standardized assessments use. So that first screenshot here on this slide, the top portion of this slide, is that screenshot of the publication for the original publication of the CFIR, the Consolidated Framework for Implementation Research. And again, those three barriers that I just mentioned, the language used to describe those barriers, that language was drawn from the CFIR framework. The second screenshot on the lower portion of this slide is the publication known as the Expert Recommendations for Implementing Change Taxonomy project. So that is, or rather the expert project. Oh, let me start this slide over. So the first screenshot here on the top portion of this slide is the publication for that CFIR framework that I referenced. So there are three main barriers that we identified through our scoping review. The language that we put on those three main barriers, that language was drawn from this Consolidated Framework for Implementation Research by Laura Damschroeder and her team. But on the second portion of the slide, the lower portion of this slide, we have a publication that, if you've heard about the implementation strategies or the ERIC taxonomy, that screenshot there represents that ERIC taxonomy, which is a list of over 70 implementation strategies that are hypothesized to help support the use of evidence-based practices into routine care. In this case, our evidence-based practices include the Action Research Arm test and the Fugl-Meyer assessment. And I bring these two publications up because they were instrumental in helping us select the implementation strategies that we wanted to deploy in the hopes of improving practitioners' uptake of both the Fugl-Meyer and the ARAT at Ohio State. Which takes us to step two, which is me walking us through how we selected and tailored our implementation strategies. So as I mentioned previously, the ERIC taxonomy was critical in helping us identify what implementation strategies we wanted to deploy with Ohio State, and the CFIR framework that was also instrumental. And we, if you've not heard of the CFR, I'd recommend checking out CFR's technical assistance website at cfrguide.org. If you go there, you can locate what's known as the CFR-ERIC matching tool, which is an Excel spreadsheet essentially where you can enter in to that spreadsheet. You can select the top barriers that limit your ability, your facility's ability to implement an evidence-based practice of interest. And so in our case, we plugged in our 3 main barriers from our scoping review. So our lack of networks and communication, our lack of supportive implementation culture, and our lack of access to knowledge and information. And once you identify these barriers, again, the barriers are from that CFR taxon or that CFR framework, that language there. Once you identify those barriers, then the output of this CFR to ERIC matching tool, the output would be recommended implementation strategies from that ERIC taxonomy that are believed to help overcome your implementation barriers. And so for us, we entered our 3 main barriers into this tool and our 3 primary implementation strategies that are recommended to us based on expert consensus or an expert panel. Our 3 main implementation strategies were to conduct educational meetings, create a learning collaborative, or otherwise known as kind of a knowledge sharing network, and then identify and prepare champions. And I will say though that I've heard Laura Damschroeder and her team talk about this tool, and Byron Powell's team talk about it as well. And you really have to take these recommendations with a little bit of a grain of salt, because it is based on expert consensus, and there was great variability in the expert opinions, I should say, from this project or when they were creating this tool. So for us, we had our starting point with these 3 implementation strategies that we wanted to deploy at Ohio State. And those implementation strategies are listed here in this box. But we also wanted to vet these strategies and potentially find additional strategies that our practitioners felt would help them use the 2 standardized assessments that we were interested in implementing. So we sat down with practitioners in the acute care setting, inpatient rehab, as well as outpatient rehab. And practitioners across those 3 settings also told us that in order for them to be able to routinely administer the Fiegel-Meyer and Action Research ARM test, they wanted us as the research team to develop web-based educational materials. They needed help changing the layout and the equipment that they had available to them, since both of these assessments do require a little bit of equipment. And then they also needed to have a streamlined way of documenting the results of these 2 standardized assessments. So in other words, needed to build in fields in EPIC, which is the electronic medical record for Ohio State. And so that would be that last, that box on the right, that last item there, change record systems. That would be, that would include changing the EMR to allow for more routine or streamlined documentation of our 2 assessments of interest. So in total, we've got our 6 implementation strategies. So 3 from that CFR to ERIC matching tool, 3 from our focus groups that we conducted across the stroke care continuum at Ohio State. And so now we're in the process of, I should say, deploying our implementation strategies. So again, here you've got our 6 implementation strategies, each of which are represented by a bullet point, and the timeline. So this project officially launched in August of 2021. It's still ongoing through August of 2023. So I'll walk you through individually what these strategies kind of look like in case you're interested in replicating something similar. So once we secured funding, and actually I should say, as we were putting the grant proposal together, we had to identify, we felt it was important to identify, not just because the CFR-ERIC matching tool told us to, but we also felt it was important to identify outcome measure champions or standardized assessment champions, just so we had that kind of frontline boots on the ground representation, because these are the folks that are actually implementing these assessments. So we need to make sure that we have their buy-in and kind of serve as that frontline resource to other practitioners. So we identified and prepared champions to be experts in implementing the Fiegel-Meyer and the Action Research ARM test. So we identified a champion in acute care, in inpatient, and outpatient. And even prior to us launching this project, all 3 of these individuals were part of the grant writing, grant development process, signed letters of support to indicate that they were committed to being these outcome measure champions or these standardized assessment champions. But now that we've gotten the project up and off the ground, what we found is that really each setting is benefiting from kind of 2 co-champions, so to speak. So in acute care, you've got one person that is the expert on how to administer the standardized assessments. And then you've got another person who is really that champion for scheduling and handling logistics. And if there are questions that practitioners have, communicating back those questions back to the research team. And that really holds true for inpatient as well and outpatient. So that was an interesting finding that we seem to benefit from here is having those two co-champions for standardized assessment implementation. As I mentioned, we've had to change EPIC and collaborate with information technology at Ohio State to allow for fields to be built into EPIC. So we've got on that top screenshot, you've got a field that's dedicated, or a cell that's dedicated to the Fugl-Meyer upper extremity motor score. And then that lower screenshot, you've got fields dedicated to scores from the Action Research ARM test. And this started in August 2021, this process of changing these record systems, and it's still an ongoing process because as our practitioners have begun to implement these two standardized assessments, they've now made requests that they would like to see the individual items of each assessment listed in EPIC so that they can document those scores individually as they go, and then hopefully have EPIC just calculate the final score for them. And we want this to be as easy as possible for our practitioners to document. And so it's an ongoing process of trying to get now EPIC updated so that we can have each of those individual items listed for the Fugl-Meyer and the Action Research ARM test as well. Through our focus groups, our practitioners also told us that they wanted us to develop web-based training materials that they could access whenever they needed to. So maybe they hadn't seen a stroke survivor in a while and just needed to brush up on their recollection of how to administer the Fugl-Meyer items or how to score the Fugl-Meyer items or the ARAT items. And so we created web-based materials. These are stored on Google Drive that can be accessed by scanning a QR code. You are welcome to try to scan this QR code, but our training materials aren't quite ready for widespread dissemination. So if you do scan these codes, it'll just take you to Ohio State's OTD program website. As for changing the physical structure and equipment, as I mentioned before, both of these assessments have their own sets of equipment that come with them. And I should mention that in the acute care setting, our acute care practitioners are only implementing the Fugl-Meyer. It just is not feasible based on the nature of acute care for our practitioners to take a patient to a central therapy location and administer something that's a little bit more cumbersome to transfer, like or transport, like the Action Research ARM test. So our acute care practitioners are only implementing the Fugl-Meyer, but we're able to provide our acute care OTs individual Fugl-Meyer kits that can be disinfected, because infection control, of course, being a top priority in acute care and actually all settings, but all the items in that Fugl-Meyer kit can be disinfected. In the inpatient setting, we provided our inpatient practitioners with 3 Fugl-Meyer kits that can be shared, that are stored in one central location in the therapy gym. We also provided them with 1 ARAT kit. Each ARAT kit runs about $700, and that ARAT kit is there on the lower right. And I should mention the Fugl-Meyer is there on the left in that kind of plastic pouch. And the outpatient setting, we provided all outpatient practitioners with their own Fugl-Meyer kits, and then 1 ARAT kit at each outpatient site. And we have 3 outpatient satellite sites, so 1 ARAT kit each. Certainly, we know that training is important. Training alone isn't really effective for promoting any long-lasting practice change, but if you can combine training with some additional implementation strategies, you might see some more promise there. So we did train our practitioners on how to implement both the Fugl-Meyer and the Action Research ARM test, at least for inpatient and outpatient, because acute care was only implementing the Fugl-Meyer assessment. So in total, we're able to train 26 practitioners across the 3 settings. We just wrapped up our final round of training this past month, so April 2022, and we'll conduct booster sessions with practitioners in the coming months, and also have plans to record videos administering where our research team administers the Action Research ARM test and Fugl-Meyer with 3 different individuals who are post-stroke, 1 individual with mild impairment, 1 with moderate, 1 with severe, and those videos will then be uploaded to an accessible platform, so that way practitioners can access those videos again if they need to brush up on their outcome measure skills in the case that maybe they have not had the opportunity to administer the Fugl-Meyer or Action Research ARM test with the patient in a while. So how are we going to know if our implementation strategies are actually making a change in practice? Well, much of that information is going to be drawn from retrospective chart audits. So to give us an idea as to baseline use of the Fugl-Meyer and ARAT, we conducted a retrospective chart review looking at the dates starting July 2020 through June 2021. And we saw that of all the stroke survivors that came through Ohio State, whether that's acute, inpatient, or outpatient, 3.5% of those stroke survivors participated in a Fugl-Meyer assessment, whereas the ARAT was not implemented at all. And so our goal is by August 2023, when the grant period is over, our goal is that 85% of stroke survivors will have completed either the Fugl-Meyer or Action Research ARM test. And I say 85 and not 100% just because that number is somewhat drawn from the literature, but also there's some feasibility components to keep in mind, whereas the Fugl-Meyer might not, and the Action Research ARM test might not be appropriate for those patients that maybe don't have the endurance to participate in something like these two assessments, or more importantly, maybe cognitively have a hard time following more basic to complex commands. And so our monthly chart audits that we will conduct will tell us whether or not our rates of implementation have changed over the course of time. And then in late spring of 2023, we plan to conduct a nationwide survey describing each of the implementation strategies that we rolled out and assess the extent to which those strategies are feasible as perceived by other individuals, other practitioners who represent different healthcare systems, because we don't want these strategies to just live at Ohio State. We do want them to become useful and be used by practitioners across the country as well. So thanks again for your interest today, and feel free to reach out to me via email with any questions you might have.